Good morning. I'm Dr. John Cruz, and today I'm going to be talking about digital medications for ADHD. When are we going to have them? So as usual, I'm going to start with the take-home message. And the take-home message is that we already have the technology. Actually been a product on the market for 6 years in the US that uses digital technology, sensor glued to the pill to provide information for the patient, doctor, and drug company. But I predict that ADHD medications, particularly stimulants, are going to be close to the top of the list of medications that are going to be digitized in the future. And the reason for that is 3.5-fold. So the first one is that one of the targets for medications that you can monitor very closely, and some of the previous talks were about other modes of monitoring medication, are the controlled substances. So drugs like the stimulants have a potential for abuse, a potential for addiction. Society has an interest, individuals have an interest, doctors have an interest in tracking how much a patient is using and when they're taking it, and if they're escalating their dose or other details like that, which would be nice to have good concrete information. And a related, so this is why there's 3.5, topic there is that stimulants, probably more than any other class, at least that's been documented, there is a huge amount of sharing among friends, family. So people who have prescriptions giving it to others, people who don't have prescriptions borrowing it from people who have prescriptions, rather than just buying it on the street or getting it from illicit sources. So both the diversion level and the monitoring of abuse level make stimulants a good target for these technologies. The other two points is that these technologies make most sense for drugs whose blood levels have a direct impact on their benefits. So with stimulants, what you take today is what you're going to get today in terms of benefits. I'm not saying that there's a direct, absolute one-to-one correlation between your blood level and your results. So with stimulants, how quickly the drug's level is increasing in your blood or in your brain, actually, or the receptor level probably has a role as well. But there's many drugs where what you take today doesn't have much impact. So there's less direct benefit or clear-cut correlation for day-to-day monitoring in that situation. And then the third point is that a good reason for having a monitoring system is if you're treating a condition where forgetfulness is a big issue. And with ADHD, forgetfulness is a huge issue. Again, from some of the studies we looked at in previous talks, the most common reason people with ADHD give for having missed medication doses or not taking medication according to schedule was ADD symptoms in the forgetfulness range. They forgot to fill it. They didn't get to the pharmacy on time. So forgetfulness, distractedness issues are important for ADHD. So some people have called digital medications smart drugs, and that term's already taken by another class of medications that are designed to make you smarter. So we're not going to call these things smart drugs. But digital medications incorporate a pretty broad range of possibilities, but the technologies, and the FDA has approved several of these already, are essentially using a tiny little sensor. They say this size of a grain of sand, about a millimeter on each dimension, millimeter long and wide. So a little sensor is chemically glued, affixed to a normal pill. And when that pill gets into the stomach acid activates the pill. The pill then connects by a Bluetooth, and Bluetooth is just a short-range radio frequency. So the little sensor that's now activated by the acid in your stomach communicates with a sensor, and the FDA has approved systems where skin patch is a sensor, so it's picking up the signal. They've also approved systems where a pendant worn around the neck is the sensor. I mean, conceivably, you could use your smartwatch also as the receiving sensor. So that sensor picks up the signal that the drug has been entered the stomach, and then via an app, it conveys that information to somewhere. And that somewhere could be It could be the doctor's office. It could be just to the patient's own files or to the family members they designate. So there's lots of points of variability in this system. The other big thing is that sensor or receiver sensor, it's doing both on the skin, that can collect data passively, and passively by that I mean the patient doesn't have to enter anything into it. So the system that I'll be talking about in a minute actually does monitor heart rate. It monitors activity levels, and indirectly, therefore, it could also be tracking your location, which whether or not you want that to be tracked. The system also that's already on the US market through the app allows a patient to enter information about their mood and whether or not when they took the pill. So one that allows the doctor or other sources to track the veracity of the patient in terms of when they took the pill, is that correlating with what the actual measurement system says? And the idea for tracking moods is then the patient can see direct impact of the drug on their mood, and that increases their likelihood for sticking to a plan or compliance. There's certainly other technologies that the FDA has already approved, and there are certainly many, many more that are in development. So a whole separate topic I won't be getting into is digital cameras. So tiny little systems that actually can monitor what's going on inside of you, mostly used for gastroenterology problems or issues. There's also been a patent received, an FDA approval, I believe, for a video surveillance system that's actually just films you taking your pill and actually has AI generated safeguards so they can tell if you're what's called cheeking it, just hiding it in your mouth or otherwise, which to me is a fairly creepily intrusive system. But so there are a range of technologies out there. But what I'm going to talk about next is the one product that's on the US commercial market and has been since 2017. So Mysite, Mycite, is a form of aripiprazole. Aripiprazole's brand name is Abilify. Abilify was in the first big wave of what are called second generation antipsychotics or atypical antipsychotics. So about 20 years ago, several drugs, Seroquel, Zyprexa, Seroquel's quetiapine, Zyprexa's olanzapine, risperidol, Abilify came to the market. So this was a digitalized form of aripiprazole. So in 2012, a Silicon Valley company called Proteus got a patent for the first ingestible sensor system for a drug. And in 2017, they received FDA approval for this specific product, brand name called Mysite, which was the first digital ingestion tracking system. So a reminder, the FDA process for a technology or devices is much more lenient than for medications. So you don't just have to prove that it works and doesn't kill people, and that for the drug, you have to show that it's at least as good as what's out there. And usually you have to show that it's better than anything out there or has some special reason or niche or adds something to what's already available. So the fact that the FDA approved these, some would say we need to have more scrutiny and more evaluation of these products before the FDA sort of lets them on the market. So by 2018, the CEO of Proteus was proclaiming or predicting that, quote, every medicine in the supply chain expected to become a digital object within 10 to 20 years. So not just one brand name form of Abilify, but everything out there, he predicted that this tool was so powerful, so useful. So a little more detail. So Abilify, again, the product was made by a Japanese pharmaceutical company, Otsuka. Right now, it's about the 25th biggest pharmaceutical company in the world. It was actually bigger years ago because of Abilify. Abilify itself was approved in 2002 and went generic in 2015. But during those 13 years where brand name Abilify was on the market, many of those years, it was the #1 in terms of sales generated in the US, not just of antipsychotics, not just of psych meds, of all meds, of all varieties. 2013, this single product was bringing in $7 billion for Otsuka. And as many companies do, when it went generic, they actually were able to delay that for 6 months because there was special pediatric indication for the drug. And that extension of 6 months on the patent probably earned them $3 or $4 billion. So other things in terms of price or cost right now, and I'm going to have to read my notes. So this is data mostly coming from GoodRx, but generic aripiprazole retail value, if you don't have any coupon or discount, is about $450 to $800 a month. Same price for different dosages. So $450 to $800 a month for generic aripiprazole right now, except if you go to Costco, where you don't even need any coupon, it's only about $46 a month. So with many of these other pharmacy chain stores, with a coupon, it might be anywhere between $7 and $200 a month. Brand name Abilify, on the other hand, and this is part of why they made such big profits, with a coupon, the coupon is still $600 a month. That's about $20 a pill. And if you don't have a coupon and you want the brand name, it's going to be $700 to $800 at different pharmacy chain stores. Mysite, which again, there is a little tiny grain of salt sensor stuck to the pill. They are also selling, it is sold with the patch, so there's more material and more complicated there. But they marketed that at about $1,800 a month, which would be $21,000 a year. And companies are very proprietary about their information, but in 2022, Mysite only generated about $22 million in sales, and by my calculations, and they may well be giving discounts to other people, and but that would only translate to about 1,200 people across the US using Mysite. So this product has not been a big success. And in fact, in 2020, just 2 years after the CEO predicted that every medication is going to be a digital object, Proteus went bankrupt. So for those of you who are scared of or don't like these technologies or afraid that it's going to be intrusively big, big data invading, intruding, controlling our lives, that might be good, but disappear from the planet. So actually, on the bankruptcy proceedings, guess who bought out Proteus or bought into it? It was Otsuka, the same company that has the experience with Mysite already. So part of what the critics, and some were saying it ahead of time, but certainly in retrospect, saying that Proteus took a pretty difficult, challenging drug to try to make a go technology. And part of it is, again, the major indication for aripiprazole is schizophrenia, and many, if not the most people with schizophrenia have different paranoia and paranoid delusions. So telling them, hey, we have a tracking device, we're putting it in your pill, meshes so closely with many of the paranoid fears that people are projecting thoughts into them, that people are tracking them, that people are observing them, that there's recording devices in their dental work. That makes this a hard sell for the schizophrenia crowd. I should mention that Abilify is actually FDA approved as well for bipolar disorder, and it's approved. It was the very first drug in the US for an indication for an augmenting agent antidepressant. So it's not approved as an antidepressant alone, but so there is a bigger market, and that was part of what added to Abilify's sales. I should also say that compared to the other atypical antipsychotics, part of what makes Abilify attractive and part of why it's done so well, it's not a perfect drug, but many of the atypicals cause lots of weight gain. Abilify is one of the less likely to cause weight gain. It's one of the less likely in formal studies to add to movement disorders. It's extremely unlikely to upset the prolactin system. It's not particularly sedating in most people. And it's very low risk in terms of people who have certain heart conduction problems, which may be a problem with some of the other drugs in this class. So again, not an ideal drug, and they probably, again, chose a difficult market to sell it in, but it certainly didn't do well. So stepping back and looking at the bigger picture, what good are these digital drugs? Yeah, technology is cool and neat and nifty, and part of this is borrowed from a review by Katerina Sideri, who's a Greek political scientist who she and her colleagues did an extensive sort of legal ethical review of digital drugs like Mysite. And her conclusion, which I think is not hard to argue with, is that far and away the biggest benefactor of these digital drugs appears to be the drug companies. I mean, right now, estimates are and studies indicate that less than half of drugs are taken as directed. And we know there's lots of missed refills, missed uses. If a drug company can double compliance rates, then they've doubled their profits. She also pointed out, that it's particularly a ethically murky situation where the drug company actually isn't. So the drug company is also the company marketing the digital tracking thing and has a patent on it. Part of one of the possible complications is that just a small upgrade in the software or twerking of what the sensors are doing could allow an extension of a patent, and then patients are locked into paying for very expensive drugs for very long periods of time. So are there other benefits to anyone else from this system? So one is that there's an argument that society benefits. I mean, drug abuse, particularly, we are still going through an opioid epidemic. Drug abuse, stimulant abuse is increasing and can be deadly as well. So society, you could argue, has a strong interest in checking particularly how potentially abusive, addictive substances are being used or not used. So if you're writing a prescription for someone and they're not using it, that would be useful information to know, because if they keep filling it, they're probably making it available to someone else. Doctors also benefit from this system, hopefully not directly financially, but one way they benefit is actually knowing what the patient's taking. So I see people both in psychotherapy and for medication, but for people who are coming in just for my half-hour medication visits, I always say, we have 3 things to do today. 1, I need to know what you're really taking. It may be exactly what we discussed last time. It may be exactly how it's written, but I need to know what it is you're taking, because if I'm assuming you're taking 2 pills a day and you're only taking 1, and we decide to go up or down, the basic starting point is knowing what you're taking. The other 2 things I felt my job in the medication system. So 1 is, what are you actually taking? 2 is it working, not working in terms of side effect, benefits, or do we need to change it? So what should you be taking? And should meaning ideally maximizing benefits and minimizing side effects. And then 3 is, what do we need to give you to get to the next appointment? In this day and age, it's mostly prescriptions, but before Obamacare kicked in and I worked with lots of low-income patients, it was often finding patient assistance programs or other ways to get them the drug. So being able to know exactly how many days this month the patient took it, whether they actually took dosages 3 times a day, whether they took it, were taking it in the evening instead of the morning, all that information is now potentially available with these digital medications. The downsides to that is that it may also increase liability issues. So let's say a patient took 7 pills of a certain drug, that maybe has a low threshold for overdose. Is the doctor liable if they don't do, what if the app doesn't immediately notify them, but just tells them at the end of the week? That person could have overdosed or died. What if a schizophrenic patient misses a couple doses of their medication and is wandering in traffic and gets hit by a car? Is the doctor more liable because the doctor could have seen that they had missed their doses and didn't do anything about it? So there's a whole host of potential liability issues that come up from having this new information available. And then jumping over to the patient, what are the benefits and disadvantages of it? So one is that there is some evidence that these systems can increase adherence, so can make it more likely that the patient will stick to the plan. Hopefully it is a plan and not just a dictate from a doctor to a patient. And for certain classes of drugs, we have some evidence that better adherence does equal better results. So that could be, again, translated to better results for patients. Now, I'd say the benefits are most likely with certain classes or types. So drugs where what you're taking today has a direct impact biochemically in your body, and where the biochemical impact has functional, behavioral, physiologic benefits today are drugs that should be good to monitor. So things like antibiotics, anti-seizure medicines, where we know achieving and maintaining a stable dose is important. And if you drop too low, with antibiotics, you're letting organisms that are potentially resistant to the drug proliferate. So some of the research that's being done has been on tuberculosis, and I'll say a little bit more there, HIV drugs, where we know if you're missing dose of your drug, you are much more likely to develop strains in your own body that are going to be harmful and potentially kill you. With tuberculosis, and not a lot of people are that aware of this. So tuberculosis is still a problem in this country. It's certainly much more prevalent in other countries, but because it is such a contagious agent, particularly the respiratory form, and potentially fatal, and has developed multiple drug resistances, it's a major public health concern. So in many cities, including San Francisco, where I worked for years, the public health department, for people who are diagnosed with tuberculosis, send people out regularly, send health workers to check on people to make sure they are taking their anti-tuberculosis agent regularly and as prescribed, because if they don't, again, it's just not a risk to themselves, it's a risk to the whole community. So some of the studies that have been done have showed that compared to having a worker come to your house every day, this digital medication system results in at least as good, and the data suggest better adherence, so you're taking more of the pills when you should, and patient acceptance. People like it. They are much more happy to have the pill checking on them than having a worker come out. That certainly also should save lots of money for public health services and free up workers to do other jobs. However, the downsides is that there's clearly a coercive effect. If you know your doctor's checking on you, that takes away some of your autonomy or decision. So there's a coercive element to it. It certainly brings in privacy issues. So yes, all these companies say their servers are safe, they're this or that, but who actually gets to see the data? At least in the system so far, the patient got to identify who the information got sent to, but it's not hard to imagine privacy being violated through any number of different ways. And then particularly since with psychiatric meds, or even general, whether you have HIV or not, it can be still stigmatizing in our society. Another issue that the ethicists have brought up is sort of patient guilt. If you have a condition like diabetes and you've missed a few doses of your medication and your diabetes is progressing over time, it may well have progressed over time anyway, but having this constant monitoring system may increase for some patients their sense of their own responsibility, not just for behaviorally what's going on, but for physiologic processes which may be proceeding anyway. So in terms of other costs or benefits, I have not seen anyone address or mention the pollution concern. So in the US in 2022, 4.7 billion prescriptions were filled. I'm just extrapolating conservatively that some of those prescriptions were for multiple pills a day, some were month, but that's probably at least 100 billion pills out there. And even though this is a tiny, tiny little sensor and the current ones consist of silicon, copper, and magnesium, I don't think any of the water treatment systems in the US would think if every single pill in the US has one of these sensors on it, that it's going to be a trivial problem dealing with what's going to be flowing into our waste treatment sites. And as we didn't pay attention or weren't completely aware at the beginning of what fossil fuels are doing to our world, what plastics are doing to our world, I'd say we're probably unleashing something else with potentially toxic consequences we're not even fully aware of. So jumping back to one other element, the ethicists also pointed out that forgetfulness for many of people, if they're taking the same pill every day, again, as we talked in the other tracking systems, it looks the same, it tastes the same. Why would you remember an hour later whether you forgot it or took it? But for most conditions, forgetfulness isn't an issue. For ADD, again, we know it's a major issue in terms of adherence. And I will sort of end with a little vignette from one of the first ADD patients I worked with. I've mentioned this in my book. Nice guy, smart guy, liked me, could see that there were benefits to taking this Concerta he was on most of the time. I was meeting with him weekly for psychotherapy directed at his ADHD and medication. When I'd check in every week, again, number one thing, what are you doing, Frank? He'd say, oh, I'm trying to take it every day. I know I missed it once or twice, but I'm trying to take it every day. And yet, just from the refill records, he would take about 13 months before he filled a 1-month prescription. And this was over the period of a decade. It was remarkably stable, 13 months. That meant he was taking it only less than one pill, or a little tiny fractionally more, one pill every 2 weeks. That means half the time when I had seen him, he had not taken any medication during the week. And I don't think he was lying. I don't think he was trying to deceive me. I think he was deceiving himself as well. But his organization, his forgetfulness, his ADD symptoms meant that he was not tracking very well at all what he was taking. So again, and my footnote on, so when will I see digital medications for ADHD? You could argue we already have it. So Mysite, Abilify, again, approved for schizophrenia, augmenting agent for depression, bipolar disorder, an off-label use, and there is a little bit of research of this, can benefit some people with ADHD. It modulates dopamine. It's not completely blocking it. It's not completely boosting it, but keeping it in a narrow range of blood and brain levels, presumably. So I've certainly seen a handful of patients who clearly benefited from having Abilify in the regimen. So technically, we do have an ADD drug out there. So I will answer questions. Next week's topic is not directly ADHD related. It's more general facial expressions and emotions, particularly smiling. So hello, Dennis. So no, I'm not related to, at least not that I know of, to Jack Kruse, the neurosurgeon. I've seen when I started getting online that there is at least one other doctor, John Kruse, who's sort of doing something brain related out there. Probably if we go back enough generations, we'll be connected. So if neurologists can detect neurologic diseases by inspecting the brain, can psychiatrists recognize mental illness by inspecting the brains of mentally ill people? So I've talked about that, I'd say most particularly in the discussion about testing. And the simple answer is So far, we have not found any clear-cut markers. So we have lots of variables where we can show people with ADHD have a group difference compared to people without ADHD. So people with ADHD may be in this range, people without ADHD for whatever marker or variable. So, there's people who've looked at cortical thickness, there's people looking at connectivity, there's people looking at dopamine receptor density. There's a whole bunch of potential markers, but none of them have turned out, and genetic indicators have turned out to be markers because there's so much overlap between the two groups. Yes, we can find robust group differences. So it's kind of like, the best analogy is saying, are men heavier on average than women? Absolutely. But if you just tell me a 200-pound person comes into your waiting room, does that tell you? Can you identify from that whether that's a male or a female? No, you can't. So far, and hopefully this might change, maybe not change, and particularly with something like ADHD that exists on a spectrum as far as we understand, and it's even less likely that we're going to come up with simple markers. We may come up with a marker for severe ADHD, or that nobody below this threshold on this variable is registering in this range if they don't have ADHD, but currently, no. And a more sort of flippant note is that historically, conditions, once we can identify brain conditions that we can identify definitively, sort of move from the psychiatric realm to the neurologic realm. So I'd say that Alzheimer's and dementias are shifting in that direction. Once we can definitively define them, and say, it's a brain condition, it's sort of, okay, you're not in psychiatry's realm anymore. So that's what I have to say for today. Stay healthy, stay happy, and I'll be back next week to talk about smiles. Bye.